Hello all, welcome to my podcast. Today we are going to discuss about the classification system in diagnosing low back pain with Dr. Vaidas Stalioraitis. Hello friends, welcome to the live video. We will be live in another minute. We are waiting for our guest Dr. Vaidas Stalioraitis to join us. So we have a lot of people joining us. Good. Our guest join. Uh, yeah. Yeah.
Hi, Nalish.
Hi, Vaidas. How are you?
I'm really well, thank you. How are you?
So, on behalf of all the people who have joined us on Instagram and who are seeing live, I would like to welcome you. Uh, Today's topic that we are going to discuss is the classification system of low back pain, right? In diagnosing low back pain. So there are many good, people have shown interest to join us, and also we have got many questions on that. But I think most of the questions will be covered in today's talk. So uh, let's start. I'll hand over to you now. You can start with this topic. Many people have already joined, so I'm expecting more to join as we go ahead.
Okay. Well, good afternoon or good morning, everybody. So it's morning here, but in afternoon probably in India. So my name is Vaidas Stalioraitis, who haven't met me. And I'm a specialist musculoskeletal physiotherapist from Australia. And I work clinically. I work with a variety of patients, but my sort of expertise in regards to treatment is patient with a spinal pain. And in particular, people not necessarily with acute back pain, for example, but more persistent low back pain. And I think the reason why we're having this sort of live discussion here, because we know that lower back pain is a leading cause of disability. And in Lancet, it's been published in 2018 that over the last 25 years, the disability hasn't reduced, but in fact is increased by 50%. So if you think about it, we got all this technology, we think we have more knowledge, and you kind of would think that we would manage patients much better than 25 years ago. But in fact seems to be opposite. It seems that disability is on the rise. So it's 50% of increase in disability in comparison to 25 years ago. And that is, I think, what is important. It's really important then to see, okay, what are we doing wrong? where can we improve, and in terms of our maybe assessment or treatment approaches. And certainly a lot of people, I think, and also clinicians, when people come in with a back pain, and especially the patient reports back pain on a higher scale, we tend to intuitively assume that these patients will have more maybe damage in the lumbar spine. Maybe we'll have something really sinister going on in the lumbar spine. And sort of not only physios, but also doctors, then what they do, they tend to send them for x-rays or MRI scans and CT scans. And what we know that, especially in acute back pain, or what our recommendations are or guidelines are, that probably is not to send people for x-rays straight away and to look at that sort of what might cause the back pain, or like, because it seems to that be associated with more fear, more anxiety, and in fact more disability. Because people tend to assume if I got a disc bulge, that means that is I'm not going to get better, or I must rest and not do any physical activity because of that. Or if you got some kind of facet joint degeneration, that also they make an assumption, so, okay, my back is weak, my back is crumbled, so again, I need to be careful what I do, or maybe sort of go into this maladaptive behavior and become a bit more sort of protective of the spine. And I think it's not only an issue like in a health profession like we are, but I said in other parts of the world, what we know that a lot of GPs, they tend to send people for x-rays and for different investigations, which we know potentially has a negative effect. Certainly there are exemptions to the rule. If you sort of suspect people that they may have some sinister conditions, such as maybe fracture or infection or cancer, absolutely these people would need to go for investigations and then do appropriate management for that. But we know these are red flags, such as fracture, infection, cancer. It's really less than 1% in general population, so it's very rare, and probably some of you will never come across in your lifetime. But I think it's important to be aware of it. And certainly the specificity or sensitivity of our questions about the red flags are not great. But I think it's important to screen, even though the likelihood is very, very low.
Yeah.
So in regards, so I kind of want to give you a bit of a sort of in a nutshell where we are in regards to the spinal pain and what we currently do. So even though what we know, if we look at the guidelines, for example, United States of America, we know that in acute spinal pain, in terms of the treatment, we know that manual therapy, acupuncture, massage is indicated. But more in a chronic, probably, or more persistent pain, the biggest sort of messages would be that treatment would be like cognitive functional therapy is a priority, as well as manual therapy in some cases, exercise as well. But certainly, probably not an X-ray. Now, if we look at pharmacological management, we know that painkillers are not a priority, in fact, in acute back pain or even a chronic back pain. And certainly more education, exercise, manual therapy would be priority for these people. So even though the guidelines suggest and tells us what to do in terms of the evidence, not many people still follow that evidence. And I think that is a problem. So it's important to know the guidelines around the world.
Yeah.
But let's get back into that classification system. So for I'm going to cover a bit of that epidemiology, a bit of the guidelines, what's out there. But the reason why I think classification systems is important for us as a physios, so really to understand what is the main problem for the patient and what the contributing factors to the problem. A lot of classification systems, like such as there are different classification systems, like based on risk, for example. So it's a StartBack tool, which is classification system has been developed in UK from Keele University. They look how patient is at risk in developing persistent pain. So if a patient scores low on that risk factors, then we don't need to do too much treatment on the patient. We don't need to over-treat or over-x-ray the patient. So it may be just with education and some self-exercises. But if certain patients are more moderate to higher risk, we probably would need to spend a bit more time with this patient to make sure that they don't fall into that category of persistent pain. Because we know around 60 to 70 people who experience the first episode of low back pain, 60 to 70% of these patients are going to have pain 1 year follow-up. So it's a big problem. So we want to catch them early. Now, other thing, other classification system based on mechanism, such as Mackenzie's system and Sullivan's system, both systems are good. What we know from the research that Mackenzie is more appropriate for acute, subacute back pain, which is quite valid. And maybe the Peter Sullivan seems to be a bit more with persistent back pain. It's a better option because it considers psychosocial factors and so on. But I think as us for physiotherapists, it's important to understand what is the main problem the patient comes to presents in the clinic. What are their functional limitations are? Like maybe they can't bend or they can't walk. And also what are their goals and expectations. So if we got this at the beginning, then we can tap in what is important for the patient, rather what we think is important from our experiences and what we normally do in the clinic. Now, other thing is what's important as we go down into that classification system to understand, is the patient's got specific type of lower back disorder or non-specific? And we know that maybe 85% of patients presenting to our clinic will have non-specific lower back pain disorder. And what that means that the patients, we cannot, the patient's symptoms does not correlate with with imaging, for example. So we cannot blame the structure. So if you think about an example as a migraine, patient with a migraine, we don't have any test such as to kind of diagnose a migraine because it doesn't show in the brain. In fact, that something is wrong with the blood vessels or something is wrong with kind of cortical areas of the brain. So they say thinking of low back. But and then there is a specific diagnosis. And specifics of what we talk about, maybe the patient's got discitis or nerve root compression that correlates with imaging. And this person's got specific disorder. So either specific or non-specific. And they said non-specific will by far is more common in a clinical presentation. Now the other thing is what is important, as you go down the scale or the classification system, it's important to understand, has the patient got acute low back pain disorder? Because the management might be slightly different versus subacute, recurrent or persistent low back pain disorder. And again, acute, like we said, maybe treatment, if it's a mechanical back pain, treatment with Mackenzie or Maitland or Mulligan would be quite appropriate for this patient. But maybe not appropriate for the chronic and persistent back pain patient. So once you understand, and then again, acute pain, what is reported in the literature says less than 6 weeks, and more chronic is more than 12 weeks, and somewhere in between is subacute. So it's kind of, we got this sort of range of how to classify acute, subacute, or chronic back pain. Now, as we then go down further into the classification systems, I think it's important to understand the pain. And pain, one of those things that, like we said earlier, if the patient's pain is very high on the scale, we think something is really wrong or sinister going on. But the pain intensity, it depends on a lot of factors. Expectations, experiences, fear and worry, and the context of when the injury occurred. So I'll give you an example. For example, if a patient comes to your clinic, well, not in a clinic, if a patient's, for example, like an old lady, she's at home by herself, and she, for example, fell over and fractured her hip. So she's got a lot of nociception or a lot of basically tissue damage, but at that time, she's by herself. So her priority is really to try to get to the phone or mobile phone to call the ambulance. So in that time, in fact, she may not experience any pain. So what it means, so she's got a big, massive musculoskeletal injury and no pain. Because of pain is not a priority for her. Priority for her is survival, to call the ambulance to come and get to the hospital. So another example, the patient who has, for example, previous bad experience with low back pain, and maybe it took him a long time to recover, or maybe he lifted a heavy box and that associated with some kind of friend who had a lot of experience of pain. So their pain might be much higher than the old lady's pain because of their past experience of traumatic event or perception of that.
Yeah. Yes.
So I think we cannot underestimate those factors such as experiences, the context of the injury, and pain, because pain is quite subjective. So we should be aware of that, basically.
Yeah.
Now, the other thing is once we know and understand the pain types, such as maybe the pain is more receptive or inflammatory or mixed or neuropathic, then, of course, then the treatment would be quite different. So patient with an inflammatory back pain, maybe non-steroidal anti-inflammatory drugs might be appropriate for this patient. But maybe the patient's got a pure mechanical, more receptive pain. The first priority would be certainly education, some manual therapy, massage, acupuncture. Okay? Patient with neuropathic pain, well, maybe we need to do some, again, manual therapy if it's indicated, or maybe he needs to go on some kind of other medications, especially if they've got spinal stenosis, inflammatory, or that neuropathic related pain. So again, maybe some of the corticosteroids might be important for this patient to reduce that swelling of the nerve root. So I think it's important to understand the pain types and how they present in a patient.
Okay.
Now, as we go along the classification system, we need to also think about psychosocial factors. And psychosocial factors, again, probably more dominant with that more sort of persistent and or maybe subacute to persistent low back pain. But certainly we need to explore it in acute back pain as well. Because if these things are dominating, this patient may crumble and that kind of become that chronic patient. So in the psychosocial category, we need to look at the things such as cognitive factors, attitudes, beliefs, expectations, because we know if the patient's got low self-efficacy, low expectations, and they don't trust in the therapy, these people tend not to do so well with a therapy, for example. Also, affective factors such as depression, anxiety, stress, fear, worry, frustration. These are the factors that, in fact, are poor prognostic factors and can lead again to that persistent disability. And again, anxiety is because people or the patient may not understand what is the problem. That's why he's anxious. And once you do education, maybe anxiety reduces and that's fine. For some people, they have maybe pathological anxiety like bipolar disorder. And that needs to be medicated and be addressed with an appropriate like psychologist, for example. Now, other things such as social factors, education, employment, relationship are also quite important factors because we know that on the lowest education of people who are less educated, who are in a lower social economic status, they again tend to be a bit worse from a research perspective. So I think it's important to understand what other psychological factors might be adding to that picture of the patient's presentation and address accordingly, either through your therapy, like cognitive functional therapy, or maybe if it's a clinically depression or bipolar disorder, we need to send the patient on and manage it in a multidisciplinary treatment.
Cool.
Now, lifestyle factors, what we know that either the low physical activity or too much physical activity is a risk factor for developing back pain. So somewhere in the middle is really good. So it's important to know how much people normally exercise or what's the normal physical activity. Has it changed since the low back pain, more or less? And really kind of, so these are the things probably we can incorporate that in management later on if it's appropriate. Also, lifestyle factors, we know that body fat index or body mass index is a risk factor as well of developing back pain or any musculoskeletal pain, in fact. So it's important to ask, has there been a change in body weight in a patient presentation? Less or more?
Yeah.
And again, as a part of the big picture, we need to possibly do some management in regards to the body weight or some advice as well on that.
True.
Now, functional behaviors will look at the adaptive and maladaptive behaviors. So adaptive behavior example is if a patient was running and kind of sprained the ankle. So in acute stage, the patient may have limping or protective responses, and that's normal responses to their current status. So, but if the patient's still limping after ankle sprain 3 months later, that would be maladaptive. The disorder should have healed, but for a reason it hasn't. It could be for many factors. Maybe didn't ask for advice, maybe poor rehabilitation, or maybe fear or bad diagnosis, and the patient is fearful and protective. So, and more commonly, maladaptive behavior is more present in that persistent back pain. And that's why I think it's really important, again, to identify that so we can target that maybe with symptom modification, with all those kind of things, to we can change that. So once we go, as you can see, we're going step-by-step process in kind of coming to the diagnosis, yeah? And then after we look at that, either adaptive or maladaptive behavior, then we'll look at that, is the patient's got movement impairment disorder? So movement impairment, I think about that mechanical back pain, that is limited movement due to pain, actively and passively. So actively, you look at the range of motion or combined movements, and then you use your pivots and pavements. And if you see that if the motion segment is stiff, so we certainly, manual therapy or you've got lots of muscle guarding, like massage, would be very much indicated for this patient. Now, if it's more related to the motor control, so then I'm thinking more, again, mechanical back pain, but it's related to that it's poor movement pattern that possibly is overloading particular structure, maybe facet or the disc, that sensitizes the tissues. So then we can work on the movement pattern, how we can change that, and maybe look at the contributing factors why the movement pattern is dysfunctional. Maybe it's due to the tone in the back muscles, maybe it's a weakness in abdominals, maybe weakness in the glutes or lower limbs. And the contributing factors would be important in addressing that, whatever we find. Okay? So at the end of it, all those things that we discussed already, we need to come to the diagnosis. So diagnosis would be either specific low back pain disorder or non-specific. And then we'll look at the stage of the disorder. Is it acute, subacute, or chronic? Then we'll look at the pain types. Is it nociceptive? Is it inflammatory? Is it mixed? Is it neuropathic? Or maybe a central sensitized patient? And from there, then we need to think, okay, what is we can address as a physio? And maybe what other things we may need to get help from other professionals, pain specialists, rheumatologists, and neurologists maybe potentially. So, but what we, in a nutshell, we know that in terms of the treatment, non-pharmacological, we know that really exercise is very, very important. Education is very important. And then manual therapy and massage acupuncture comes into that umbrella as well. So that would be kind of, in a nutshell, why the classification system is really important, to really try to understand that not only where the pain is, but the type of pain and the context and the contributing factors to that.
True. That's nice. Yeah. So, Vaidas, there are a couple of questions that I have got. One thing is, I want to ask, Peter Sullivan had published, one of the research recently, I think that's last year, about cognitive behavioral therapy, cognitive functional therapy in, with the case reports. So, do you practice those questionnaires in your practice?
Absolutely, yeah. I do.
How important, because it's a lockdown right now, and we are getting a lot of calls in last 7-8 days. We have got a lot of calls of having back pain, and they are sitting at home doing nothing. They are not able to move out. They are not able to do exercise because they don't have access to gyms. They don't have access to parks. So in those kind of situation when we as a physio are doing online consultation, do you recommend to use those kind of forms for them to fill up and send it, because most of the patients are actually having chronic back pain, which is like they used to, they were actually getting better, but suddenly because of the lockdown and they are at home, they are stranded at home, and the pain is again started to spike up. So do you think that it is a good idea to use those forms for
I
them?
think it's quite important, and I think, look, because they've got a lot of time at home now, and they're really
Yeah.
not doing probably much, so I'm sure they've got
Yes.
plenty of time maybe just to have a look at those questions and to answer them. And the ones in particular I would suggest you guys to send them through is Cerebral. It's a short form Cerebral. It's 10 questions. And really, if you can identify many factors that might be the reason why they have pain. Not only that, but also what is the drivers for pain? Is it stress? Is it lack of sleep?
Yeah.
Is it a bit of a depression? So by answering those questions, if they score higher, I think more than 5 out of 10, I then would design my questionnaire according to that and explore those domains. So short-term Cerebral is really good, and also I think patient-specific functional scale. So they do nominate 3 activities they have trouble with, let's say sitting for half an hour or walking or bending.
Yeah.
And then from there, then you can really address that in your, through the online consultation maybe. So ask them to bend, show them how he bends, show them how he sit to stand, look what strategy they use. People with a chronic back pain, commonly, they have a lot of core contraction in their abdominals.
Yes.
And they tend to brace. They tend not to breathe. They tend to use their arms to get out of the chair rather than using their legs. And some of the strategies that they potentially implement, really using the lower muscles rather than the back, which then gets more tight, more tension in there.
Yeah, absolutely. Well, there is one of the person who has requested if you can put your assessment forms on your FB page or any of your platform, if any assessment form that you may be using.
I know, look, what
that's the question I got it in this.
Yeah, I think the systems are a bit different probably in Australia and other parts. And also because of working
Exactly.
Because I'm not a boss, I work in a big organization, so unfortunately that would be conflict of interest.
True, very true. So definitely it's a very important and very very informative series that we are doing on Instagram. At least people are at home and they can learn. Slowly the lockdown is
easing off,
going to open.
So maybe I can come to India and try your amazing food again. I'm looking forward to it. And do a good course so people can join us on a spinal course.
Definitely. Yes, definitely. I think if everything goes fine, so definitely we have one of your course in July end. So that is one. There is one of our old friend has asked question, Arvind Yadav. How are you treating your low back pain by self? I don't know what does that mean, but how do you self manage your back pain at home? I guess that's what he's asking.
Well, good question, Arvind. And believe it or not, I can tell you from my experience because 2 weeks ago, I was literally making a bed, and I sprained my back, and it was maybe I get back pain once a year, and I was locked up completely, and the pain wasn't getting away. Basically, I tried to massage or whatever, but it was very difficult. So the good thing is that the lockdown here is a bit eased off in a way, so we can start mixing and wearing masks. So my colleague came. In fact, what she did acupuncture on me, and it really helped to ease off the muscle spasm in there. So what I'm saying, and this is a manual therapy. So what we know, and it works really well. So she did me 2 sessions, and I was pain-free in 5 days. So that's why I think, guys, and it really makes sense in terms of acute back pain, massage, manual therapy, acupuncture can work fantastically well. But And probably if I continuously doing maybe mulligan snag or whatever, I would have got better, but maybe in a couple of weeks, not in 5 days. So that's what, yeah.
Okay, and well, there is another question that has come: how to treat others, suspicion having acute back pain and not even able to move from bed. Okay. It's really hard to understand this, but just I'll try to explain. So there is one person who has asked how to treat others, assess patient having acute back pain and not able to move from bed, and X-rays and MRI as normal. Well, I think. So basically, what I can understand from this question or info from this question is, like, how to assess a patient having a acute low back pain and having X-rays and MRI normal. Well, I think you have already covered this when you were talking in terms of how to assess and everything. Yeah.
But just a couple maybe comments. So if a patient can't really move, obviously our assessment will be very limited, isn't it? So maybe if a patient is totally in spasm from the pharmacological point of view, there is some evidence to show that maybe anti-inflammatories could work, maybe for, or maybe muscle relaxant to begin with. And then once they start to be able to move a little bit, then you can look what movements could reduce the pain. So Mackenzie could work quite well here. Look at the direction. Maybe extension might relieve a bit of back pain, repeated extension.
Yeah.
Or maybe repeated flexion might be reducing the back pain. Maybe allowing to breathe in abdominal wall, descending the diaphragm can also reduce the tone in the muscle. Because often when there's acute back pain, there is a muscle contraction. So keep it simple. Don't overthink. But also if it's too painful, obviously we can't do too much assessment. By questioning, ensure that there is no red flags, or there is, the disorder is more inflammatory and it's a mechanical, then leave it for a day. Let them rest a little bit and then start looking and do assessment a bit, sort of thing, in regards to movement, see what helps.
Yeah, absolutely. Well, I think that's the end of. There is no other question, I guess.
Okay.
Yeah, there is no one. Yeah, I think we have addressed almost all, and most of the thing must have been cleared while you were taking the about the classification of low back pain, classification for diagnosing low back pain. Well, there is just one question that has popped out. How to treat pain at ASIS? I mean, it's movement pain, but area is anterior and a pain is while bending. Well, it's.
You mean when you feel anterior pain? Is it abdominal pain? Is it the hip pain? What is it like when bending? Anterior pain?
Well, there is no specific. What the question is? How to treat pain? Okay, at ASIS. I mean, it's a movement pain, but area is anterior and a pain is while bending. Well, it's very difficult to comment if we don't have.
It's a bit difficult because you see, if the pain is anterior.
It's a hip pain. Yeah, that's what you said.
It may not be back-related pain as well.
Yeah.
It could be maybe the hernia. It could be, muscle strain, or could be anterior hip structures, or femoral nerve can refer pain into anterior region of sort of thing, where ASIS is. So it's a bit difficult to say, but to comment on that. Yeah, but.
Yeah, but I think she has put it's a hip pain. Well, that's what she says. So it's a hip pain. Yeah.
So then we need to do assessment on the hip. So maybe it's in another talk we can talk about the hip pain.
Yeah, absolutely, because it has a very close relation between low back pain and the hip pain. So it's
and I think that's right, because low back can refer pain into the hip. So what it means, so if you did an assessment of the back pain and you pushed on the back and it's no pain and it's not referring you to the hip, probably it's not the back. Maybe the hip that is, on itself is the source of symptoms, and then we need to do assessment on that, on the hip.
Okay, and there's one more last question that we are taking now: how to treat SI joint pain and how to figure out whether it's coming from lumbar.
Okay, so sacroiliac joint pain, usually the pain is a bit more localized where the SAJ is. where there is a lower back pain, it's obviously a bit higher, normally from the pain location. Now, to differentiate between SHA and lumbar spine, we would need to do SHA test. And by last-leg classification system, we do pain provocation test, 5 provocation tests. So we do compression and distraction for SHA joint. We do thigh thrust through the femur, looking at for the pain. We do the PA on the sacrum, and we do get gaze length test. So just have a look, guys, at the last-leg classification on pain provocation test on the sacroiliac joint. So if that's painful, we can do them a variety of things. We can do Mulligan.
Yeah.
We can maybe do glute activation to see if the pain reduces. But if the test is 3 or more out of 5, then would be likelihood of SHA pain. If it's 1 test positive, probably unlikely. And if it's no pain, if the pain is in the buttock, but SHA is negative, certainly can be lumbar spine. So I would assess, palpate the spine, and look for the source of pain and treat accordingly.
Okay. The questions are popping out now. So there is one question. Is one of our old friend, is there any, just a second, is there any particular characteristic to understand the inflammatory low back pain?
So inflammatory low back pain, if you think about it, it's really looking at 24-hour behavior, isn't it?
Yeah.
So the patient's pain going to be probably constant. Yeah, and patient's pain may be also at night when they're turning in bed, for example, is also quite painful. But in particular, there is a lot of stiffness and pain first thing in the morning, more than an hour or half an hour. And so it gets a bit easier when they have a hot shower, and so on. So that would be the indication of that inflammatory pain. If it was pure nociceptive pain or mechanical nociceptive, so that would be only movement-related pain. So what then forward is painful, when they come back to neutral, is either completely resolved or maybe minor pain. So so that would make a difference. So basically night pain and stiffness in the morning, more than half an hour.
Okay. And I think inflammatory pain also has a typical characteristic of having a night pain. That is like disturbances in the sleep with the pain.
And
patient.
And anti-inflammatory medication helps.
Yes. Not in mechanical.
Yeah. Anyway, and it reduces the pain. So then probably is inflammation is part of the picture in a patient presentation.
Okay. So there is one more question. I think we'll take this as a last now. What's your advice on lumbar disc herniation? How long complete rest is needed?
Look, I think in terms of now the disc, and again, just talk about the research a bit. We know as we get older, there is changes happen in the disc, in the facets. So, and it's been a study on people who were totally symptomatic, and they looked at the x-rays basically when they're 20, 30, 50, 60. What they saw that as they get older, even after 8 or 30, they were common to have disc bulge. It was common to have fast joint degeneration, but they had no pain. So, but certainly some days you can have pain, and and it's coming from the disc. So there is no, in a guidelines, there is no contraindication to start early mobilization even with a disc bulge. So you would look at that maybe directional preference, either extension or flexion, whatever release the pain. So don't be afraid of a disc. I think disc heals, but look at the direction which way the symptoms may be relieved.
Yeah, and also I think there was one study that shown the disc generation and disc herniation was also age related.
Yes.
So actually you don't have to believe on the disc herniation or disc.
That's right. So basically it's having like a gray hair in the hair. So when it's a normal aging process, and I think before we used to be very worried about the disc. Let them make sure that they're in bed for 7 days or whatever it might be. But it's really, I think, more an old-fashioned way of managing the patient. We need to have more active approach. Certainly, like I said, it's a very inflamed back pain. Anti-inflammatories, maybe a day, a bit of rest is okay, or 2 days, but then start mobilizing as soon as the patient is able to. Bed rest has very negative effect long-term.
True, very true. Okay.
So don't be afraid.
Yeah, absolutely. And thank you, Vaidas. I think we'll end the today's session. I think we have already spoke almost for 40 minutes. Oh, that's quite long.
No problem.
Yeah.
No problem.
Okay, so
guys, keep well. Make sure that you kind of, don't give up. Just keep being interested in physiotherapy. We're in a good profession. And when the lockdown is over, we can return with lots of energy and with new knowledge and help patients.
yeah, absolutely. Thank you very much, Vaidas, and it was awesome to have you again. And I think we'll have a few more sessions over a period of few weeks, definitely, and we can learn a little more from you. And we can take advantage of your expertise.
No problem at all.
Okay.
All the best, everybody. Have a good day.
Thank you. Yeah, bye. Thanks for joining us. Thank you.
Thank you for watching. Subscribe to my channel Nilesh Physio Sutra.